Good evening, and welcome to Talk Show on Breast Cancer, an initiative by Integrated Health and Wellbeing Council, supported by Dr. Reddy's. I'm Riddhi Lakra, Assistant Editor, IHW.TV. Breast cancer is the most commonest malignant disease in Indian women. Over 1 lakh new breast cancer patients are estimated and diagnosed annually in India. When we talk about the survival rate of the patients with breast cancer in India, it's poor when compared to the Western countries. That is due to the early age at onset, last stage of disease at presentation, delayed initiation of definite management, and inadequate and fragmented treatment. While the awareness about the disease is there, it is required that we create more awareness about the risk factors involved, which can turn and even reduce the impact of the disease and the treatment process. To talk about like the generating breast cancer awareness and reducing the risk factor in women, we have with us panelists joining. We have Dr. Shona Nag, Director Oncology, Shaidri Hospitals, Pune. We also have with us Dr. Suresh Advani, Director Department of Medical Oncology, Shushrut Hospital, Mumbai. We have with us Dr. Vaibhav Chaudhary, American Oncology Institute, Nagpur. We also have with us Dr. Raj Nagarkar. He's the MD, Chief Robotic Surgeon and Surgical Oncologist at HCG Manvata Cancer Center at Nasik. Lastly, we have with us Dr. Neeraj N. Bhatt. He's a consultant medical oncologist, Hemato Onco Clinic at Barodra. I welcome you all for this panel discussion to create a to talk about a very important topic of how we can reduce the risk of breast cancer. As Dr. The other panelists have not yet joined, we would just wait for them. While they join, we will discuss with them. Dr. Raj, I would start with you first. When we talk about the early signs and symptoms of breast cancer, so what are the early signs and symptoms of breast cancer, and how do we differentiate the signs that people should be aware about, and how it can be differentiated with other lymphomas, etc.?
Riddhi, at the onset, let me say that this is a wonderful initiative because in a country like ours, where considering the extent and volume of breast cancer in Indian women and men also, it is not only a women who get breast cancer. I think the important key factor is awareness about breast cancer. So while we are talking about the possible symptoms and signs associated with breast cancer, it is pertinent and extremely very important for every lady in this country to be aware that she is at risk of developing breast cancer. So by the time a lump is noticed, normally when we say what are the signs of breast cancer, the usual signs come up with any lump in the breast, nipple discharge, any swelling in the armpit, any redness in and around the nipple areola complex, or puckering of the skin overlying the breast, or your breast shape alters as compared to the opposite breast. During pregnancy or during lactation, the breast suddenly becomes large, what we call as an inflammatory breast cancer. And once the cancer is spread to other parts of the body, then you could have a swelling in the neck, or cough, or jaundice, bone pains, headache. These are the usual signs and symptoms, as you call it. But before going or embarking on those, I would make it an appeal on this platform that every lady should learn to examine her breast herself, because a lady knows her body the best. So breast self-examination can help pick up many cancers in a primary stage and will help us. The small minor changes of lump in the breast can be picked up very, very early.
Thank you, Dr. Raj, for that opening, very important statement what you have given about every woman should know about their body, and they are the ones who can actually find out the lumps or the early signs what we're talking about. Dr. Vaibhav, I want to come to you in the same lines. Like when we talk about what are the types of the breast cancer that are there, and are they different from the each other? What is it like?
Yeah, I am a medical oncologist. Basically, I deal with medical management of breast cancer. So for me, it is very important, and we actually tell each and every one of our patients as well that breast cancer is not one disease. Actually, it is molecularly a collection of few different diseases, and every disease behaves differently. And the matter of the fact is, the therapy, especially the medical management after the surgery is done, is varies according to the molecular profile of the cancer. So broadly speaking, for the ease, actually it has been divided into three broad categories. One is, there are some receptors on the breast cancer, that is estrogen receptor, progesterone receptor, and HER2 receptor. So according to the presence or absence of these three receptors, these are tested on the your biopsy basically. When you do a biopsy and diagnose that this is a breast cancer, then automatically the next step should follow, that what kind of breast cancer is this? Because all the three are different. The majority are estrogen receptor positive. They are estrogen responsive, and they do very well for years together. Even in stage 4, they do very well for years together on hormone therapy. They need not even get chemotherapy as well. Second is estrogen negative and HER2 positive. So these are the cancers which are a bit aggressive, more fast growing, and they can be controlled with newer targeted therapies like trastuzumab. So these are not newer, obviously. It has been 20 years we are using trastuzumab as a target therapy in this variety of cancer. So with the advent of certain new drugs like pertuzumab, TDM1, trastuzumab deruxtecan, these are newer drugs which are coming. These are just targeted therapies. They are targeting that receptor HER2, and which actually drives the cancer. So that's why they are very effective, and that also has actually increased the survival of such patients. Third one is, when all these receptors are negative, estrogen receptor negative, progesterone negative, and even HER2 is negative. So here actually we are dependent more and more on chemotherapy. So these are broadly three categories of the tumors. One is hereditary, that we will come to in the later part of the question as well. So that is around 5 to 10% of all the breast cancers are transmitted from one generation to another through genes. So that is a separate entity altogether.
Thank you, Dr. Vaibhav. Dr. Neeraj, Dr. Neeraj, can you hear us? Dr. Neeraj, as in the beginning,
Yes,
Dr. Raj
I can.
Yeah, as Dr. Raj was telling in the beginning of the panel when he started, it's not just that the breast cancer is with the women only; it is also the male who get the breast cancer. So, how is it different from the female breast cancer, and who can get it actually?
Well, just like there are documented risk factors for development of breast cancer in female, no such risk factors have been identified for male. And if you look at the incidence of male breast cancer, it is very, very rare compared to female. So, male breast cancers, although it is a separate entity, we might be seeing, say, once in a year. One case is a year, while we might be seeing daily cases of breast cancers in females. So, if we compare the numbers of breast cancers in females versus that in the male, there is a large difference. And as I said that advanced increasing age, nulliparity, hormonal tablets, these are certain factors. Obesity are certain factors which increases the risk of breast cancers in female, but no such risk factors have been documented for male. Another peculiarity of male breast cancer is it tends to present at increased incidence of locally advanced, because the breast substance is less in male. Whenever they present, more often than not, they present with skin involvement, they present with chest wall involvement. So these are certain salient differences between male and female breast cancers.
Thank you, Dr. Neeraj, for highlighting that point that how the male breast cancer is different from a female breast cancer. Dr. Raj, I want to come and ask you is breast cancer transferred hereditarily? Is there a thing, or is there a risk of acquiring breast cancer increases within a family history? Is it always the case, or is it a different?
Yeah, I think I lost you in between. I think you are asking about hereditary breast cancer, right?
Yes, doctor.
Yeah. See, hereditary breast cancer, as Dr. Vaibhav also pointed out, it is a definitive distinct entity. Almost 3 to 5% of breast cancers tend to run in families, not only in females, even in males. In fact, as male breast cancer, though we say it is, if there are 100 patients who are with breast cancer who present to you, 1 in 100 is likely to be a male breast cancer. In fact, from our own institute, I have my published data of 180 male breast cancers whom we have treated. And one of the risk factors, apart from, like, there are 2 publications which came from our own center. One was about a series of 180 breast cancers, and second was post-COVID. We did present a hypothesis and a data which was substantiated by 16 other institutes world over, where post-COVID, considering the increase in the HRCT associated radiation which has been given to so many of the males, that is definitely going to carry in some risk of developing breast cancer in males maybe a decade or 2 from now. So among the risk factors for male breast cancers, which also happens to be a risk factor for female breast cancer, is a BRCA mutation. Because now we have really come forward to a stage that majority of our patients now undergo BRCA mutation, germline mutation studies. We do regularly for almost all the patients who are less than 50 years of age, or all triple negative breast cancers, beyond doubt they undergo. We are seeing patients, and if a lady is positive BRCA mutation, then we even screen the male members in the family, and we have picked up male members of having BRCA positive cancers in the form of both breast cancer as well as prostatic cancers, which are known to be very common, and also pancreatic cancers, which are very well documented that they are more common in males, where BRCA positive males. So regarding hereditary breast cancer, it's again an entity which one should be very well aware about, at the same time not being paranoid about. I'm using the word paranoid very clearly because in a country like ours, where we have literate population but uneducated population, so literacy does not get translated into education. I have seen patients where they find it difficult to get their daughters married off just because the mother has breast cancer. So a hereditary risk of breast cancer is to make you more aware of the potential risk which you carry, and that only means that you have to be little more cautious. Dr. Vaibhav would agree with me that hereditary transmission is not a vertical transmission. So if a mother has breast cancer, not necessarily that every daughter she has is going to have a breast cancer, or every sister is going to have a breast or ovarian cancer. So it is not only to prognosticate or identify the risk in family members. Now it also has, since I'm talking about BRCA mutation, it has got a significant implication on the treatment of that individual patient also. Depending on her BRCA mutation status, the surgery option changes from breast conservation to mastectomy, or prophylactic mastectomy on the opposite side, or doing if she has completed her family, doing her prophylactic risk-reducing bilateral salpingo-oophorectomy, where we remove the ovaries and the fallopian tubes if the lady has already completed her family. And even after completion of chemotherapy radiation, in a small group of patients like triple negative breast cancer, whether to give the patient adjuvant olaparib or capecitabine is also decided based on the BRCA report. So a hereditary breast cancer, if I see a new patient of breast cancer who walks into my OPD, as a team, when we explain her that you get your BRCA mutation done along with the molecular panel, it is not to increase the alarm bells that it could be a hereditary cancer, because not every patient who has a BRCA mutation positive cancer could be having a family history of breast cancer. There could be a sporadic gene mutation also. As we say that 65% of breast cancer patients which we see in our country are sporadic gene mutation, where there is no family history of breast cancer. So hereditary risk factor is an important historical aspect which not only determines the possible cause of the cancer, but it also has a significant bearing as to how the treatment of that lady is going to plan and what are the risks involved.
Doctor, you highlighted a very interesting point that it is not always a heredity. But there is another thing that when somebody in the family is diagnosed, maybe a father is diagnosed with a prostatic cancer or maybe a pancreatic cancer, the daughters uh, are like indicated that you might get the breast cancer or ovarian cancer. So is it always a right choice that one has to go under a test? Maybe once they are like becoming a mother, like they're pregnant, maybe they have to do a test, or is it not required? What would you suggest?
I think you have pointed out a very important thing. See, BRCA mutation or a hereditary gene panel test is not a test which has to be thrown at a patient that you get it done. Actually, before you advise the patient, it's not patient, it's the family members to do the test, you have to do a proper counseling. A proper genetic counseling has to be done, because as you said, if there is if the patient's daughter is a young lady who is 18 or 19 years old, or has a son who is 21 years old, will I advise him or her to do a BRCA test? I will definitely not advise. You should wait till they complete their family. You should counsel them rightly, because you don't want to give them sleepless nights, because cancer, the big C, is a word which causes lot of alarm. You can't, like, if a girl is 20 years old and if her mother has breast cancer, or unfortunately her first degree, her masi or auntie has had breast cancer, I don't want her to sleep for the rest of the few years with that fear that I am going to get the breast cancer at some point of time. So proper counseling has to be done, wherein based on the family pedigree, you decide what is the likelihood risk of breast cancer, and we usually recommend screening for family members only and only after they have gone through a proper counseling session and they understand the significance of a positive test or a negative test. At the same time, let me please make a very categoric statement that a BRCA positive test does not mean that that individual is going to develop a cancer 100%. It is not 100%. There is a risk factor. That risk varies from around 40% to 60%, but there is still more than 50% chance that a patient who is BRCA1 and BRCA2 positive may not develop cancer for the rest of the life. So you should be very, very clear while advising a patient. And as I said, that I never counsel my relatives or none of us as doctors, just write a prescription, go get your BRCA done. That's not the way it should be advised. You have to counsel them, spend some time with them, counsel them what is the benefits of that. What if it comes positive? Does it mean that the world is going to change upside down? No, you should still continue with your professional course, complete your family at the earliest, and then go ahead with your risk-reducing surgery if required.
Thank you, Dr. Raj, for that. Like making understand like how important is counseling in terms of knowing if somebody is tested positive, BRCA positive in the family, and knowing that this is not just the end, but doing like getting a right counseling and then going for the test, and that would be a right way. Like Dr. Vaibhav, I want to come to you like on the next part of it. Like we were earlier talking about the self detection. That's like a very important thing. Like how one can self-detect breast cancer, and what are the roles does self-detection play in generating mass like breast cancer health awareness, in terms of the awareness in those lines. Also, like when should actually a woman or a man should start like doing this test, that like the after the which signs they should do it?
Yeah, that's a very important question. Now the answer is actually a bit different than what you would be expecting. Basically, breast self-detection is very important. As Dr. Raj told, I also firmly believe that it is one of the things which is lacking in our society, in our culture, and obviously we come up with very, very advanced diseases. That is our bane, and that is what is happening years together. So self-detection is very important. As such, the risk of breast cancer rises after 40 years, not before that. So there are guidelines for mammography, yearly mammography, which is an objective test which detects the breast cancer at the earliest. And international guidelines say that every female after age of 40 or 45 years, they differ basically. People agree on 40 years. Yearly one mammography should be done. Now that's an objective test. You need to go to a clinic, go to a hospital and get it done once a year. That is in national screening programs of many countries. That helps a lot in detecting the cancer at the early stage. Now, your specific point about self-breast destruction. So there are scientific trials being run. There are a lot of data, and ultimately they concluded that it doesn't help that much in detecting the cancer at the earliest. It doesn't save lives, and their endpoints were different. But in a country like India as a whole, where we are obviously at the mercy of the patient, if patient doesn't only tell that there is something wrong with the patient, then it gets very late. The detection gets very late. We don't have any program for yearly mammograph after 40 years. So for us, the self-detection, self-examination, breast self-examination is very important, because every female, every woman knows her body very well. And any subtle changes, even once a month, if she can just examine it properly, standing in front of a mirror, right from the symmetry to the consistency to the presence of any small nodule, that goes a long way here, because we don't have that program here for mammography. Scientifically, if you ask me, thus is it actually indicated or is it in the guidelines? It is not, because the guidelines are made across the world with different population, that is based on trial data. But for India, it's a very practical and very fast tool to detect those masses which are curable, rather than you get a surprise that such a big lump is there and the lady has not told anyone. So this awareness needs to reach each and every female, that you need to self-examine your breast. This has already been done in the West, in other countries. They already are doing it. And on top of that, they are doing mammography. Here we are doing none of this. So that's why we need all these things. We should not just see the guidelines and then say that, yeah, this test is actually not useful. It is very much useful in our society.
Thank you, Dr. Vaibhav. Dr. Neeraj, on the same lines of like what Dr. Vaibhav was telling about the self-detection and the mammography, which is like in India, which is not available so easily. But there are other guidelines as well. They say that self-detection is not exactly a right way. In certain population, is it like only restricted to certain population, or because of the based on the studies? But in terms of the Indian population, there are the number of the population in India is so much, but and we do not have such facilities of mammography for everyone. So would you suggest like is it a right way, like a self detection like a woman should only do, or the men only should do it?
Well, I personally feel that breast self-examination actually is a routine part of my office counseling to almost every females. Yes, it is important. Unfortunately, breast self-examination will not be able to diagnose breast cancer at subclinical level, like what mammography can do. So mammography can diagnose cancer at a situation where it is clinically not apparent, or maybe we can say stage 1 or even before that, if we can say like that. So actual benefit of investigation is by doing mammography, which should be done after the age of 40 years to every female, and maybe a bit earlier by 5 years if there is family history. This is what I feel, and I counsel to almost every female patient. Breast self-examination is, I personally feel that would increase the awareness about breast cancer, rather than it is a really important tool to diagnose cancer, because breast self-examination also requires a few technicalities which every female needs to learn, just like Dr. Vaibhav explained. Apart from that, it should be examined with the flat of the hand and in the supine position, leaning forward position, like that. So they also need to understand the into a bit technical detail. But I personally feel that it is not as much useful as mammography in prevention or of breast cancer or increasing the cure rate.
Thank you, Dr. Neeraj. Dr. Raj, I want to come and ask you, like, once the patient is like detected with breast cancer and it's been suspected, so what would be their first plan of action when they go to a doctor? What should they ask? What should be their understanding be? Because already with the news that they are being suspected with the breast cancer, they would be a little scared, they would be worried. that whether they live or they'll have their children, all those things. So what do you think the first step should be? And how do you think here the counseling is playing a very important role?
I think since we are talking more on a social platform and for the masses, a lady who usually reaches out to a oncologist or a hospital, usually she goes with a history or a palpable lump which she has noticed, or the nipple, a blood stain discharge that could be the point. So here, the first thing should be every breast lump is not necessarily cancerous. So if a lady notices a lump and she reaches out to hospital before she has undergone a mammography or biopsy, anything, then please, it should be borne in mind. There's still a possibility it may not be cancer. So every lump is not cancerous. That is my first thing. Second thing is, many a times in a country, because the lump does not cause any pain, ladies tend to ignore it. Now, the thumb rule is that usually cancerous lesions are painless and painful lesions are not cancerous. But it is not always true. We can have non-painful lesions which are non-cancerous, and also there could be painful cancerous lesions also. Once they come to a hospital, and when I see in my own clinic, then the first step in the investigation after examining, usually as oncologists, when we examine the patient, 9 out of 10 times we can tell that, okay, whether this is cancer or it is not cancer. If on clinical examination, we come to a conclusion that yes, it could be suspicious for cancer, then we advise a mammogram or a mammography, which is done, which combines a combination of X-ray of both the breast or along with the ultrasonography and a color Doppler of the breast. Mammogram will usually tell us whether is it a cancerous lesion or it is a borderline lesion or it is a non-cancerous lesion. Mammogram is always followed by a core biopsy. Core biopsy means we, with the help of ultrasonography, we take small cores of tissue from the lump. There was an era where FNAC was recommended, but now FNAC is an obsolete or outdated test. It should not be recommended for any of a breast lump lesion. So we recommend a core biopsy. Core biopsy reports are usually available in 36 to 48 hours, which will tell us whether that lump is cancerous or non-cancerous. If it shows that it is a non-cancerous lesion, then obviously we should not be bothered, and depending upon the size of the lesion, either we can just give some supportive medications or advise a excision of the lump or removal of the lump. If the report comes that it is cancerous lesion, then we have to subject that same core biopsy which has been done, the tissue which was removed, has to be subjected for certain further tests which are called as a molecular test. As Dr. Vaibhav and Dr. Neeraj was saying, we do tests called as estrogen receptor, progesterone receptor, HER2 receptor, and a MAB index or a Ki67 on the same core biopsy. And in an early stage breast cancer, if the cancer is only in stage 1 or stage 2 on mammography and clinical evaluation, then we recommend an X-ray of the chest and a sonography of the abdomen and pelvis. We do not, in early stage breast cancers, fancy tests like PET CT scan or CT scan are usually not required, which are there. Only if the cancer is in a third stage on clinical examination, in those patients, we recommend to get a PET CT scan done. Lump, then instead of doing a mammography for young ladies, we recommend a MRI of the breast, which can be done. So, and depending upon the reports, once it's like, we see in a country like ours where patient is moving around with a breast lump for maybe 6 months to 1 year, but the day she makes up her mind that yes, today I want to go to the doctor, then she is like, okay, I have a breast lump, you do a biopsy and you get it operated and removed today itself, today night itself. I don't want to wait till tomorrow morning. So for all of them, I would just put it in a way that the lump which you have noticed it today. it has started in your body a few years ago. It is not few weeks or few months. It is a few years ago. So any disease process which has started a few years ago, it has grown so slowly, it is always better to do certain tests to understand the histology, the biology of the tumor, the stage of the tumor, and then decide about the treatment. Because there was an era where we used to talk about breast lump, breast cancer, go ahead and operate first. Now it is not so. Now, majority of our patients don't need surgery first. Depending upon the receptor status, if it is triple negative, they go for chemotherapy first. If it is HER2 positive, they go for chemo with trastuzumab first. And if there is axillary node positive, even if it is ERPR positive, still they go for chemotherapy first. So we have to plan the treatment, not keeping that one day of hospital stay in mind, but taking into consideration the long-term treatment goal. The patient's treatment usually goes for 5 to 10 years. So a treatment which is going to go on for 5 to 10 years, there is no harm in waiting for 5 days and getting all the details of the tumor and then deciding the treatment.
Thank you, Dr. Raj, for explaining that. Doctor, just a thing, like you said, like 5 to 10 years. Is it always that the entire breast cancer treatment goes for 5 to 10 years, or is it just like a 6-month thing? What we hear?
I think all patients who are hormone receptor positive, 80% of the breast cancer patients which we see in our country are hormone receptor positive. So that treatment is going to go on for 5 to 10 years. Does not mean that the chemotherapy will go for 5 to 10 years. After the chemotherapy, radiation, surgery part gets over in less than 6 months, but they go on for hormonal tablets, has to be taken for 5 to up to 10 years has to be given. For those patients who are hormone receptor negative, then the treatment goes on at least for a period of 1.5 to 2 years. So it is a long treatment, but the major part of the treatment is in the form of tablets and not in the form of injections or chemotherapy.
Thank you, Dr. Raj, for that, for explaining us nicely. But I want to ask, Dr. Vaibhav, again, the same thing, in detail, if somebody wants to understand what would be the entire treatment process in a breast cancer, from the beginning, once after they are being diagnosed, what are the entire treatment process? The doctor said, it would take entirely 5 to 10 years. So if you could explain in a detail, what would be the small, in a layman term, if somebody really wants to understand what would be the treatment process, and also is it possible to treat breast cancer non-surgically, or is it always a surgical option there?
So I will take your second question first, because that is very, very important. That till date, there is no evidence or no guidelines, nothing like that, that we can avoid surgery in a curative breast cancer setting. Curative means stage 1 to 3. We cannot do away with surgery. Surgery is a very, very important part, and that is the only curative option. Without that, there is no curative plan as of now. We are actually in research. We are having a lot of new trials, a lot of data, wonderful molecules from medical oncology, targeted therapies and all. But still, surgery is the cornerstone. That is the thing to be remembered for curative option, stage 1 to 3. Not in stage 4. 4 is a different story altogether. That's a metastatic setting. We'll discuss about 1 to 3. So if a patient is diagnosed, first is the diagnosis, second, that is achieved by biopsy, and second is the staging, which is being achieved by doing a CT scan or a PET CT scan, whatever is feasible according to the stage of the tumor. And then we make a plan based on tumor biology. As Dr. Nagarkar told, that previously it was very simple. Breast lump comes to you, you operate, and then you give chemotherapy. Now with more and more data, with the advent of targeted therapies and a lot of data, we have seen that giving chemotherapy first, giving targeted therapy first for a limited period, maybe 2 months, 2 to 3 months, and then decreasing the size of tumor, or sometimes the tumor altogether completely disappears. Even with that, for example, HER2 positive breast cancers, half of the tumors actually disappear when we give neoadjuvant chemo plus targeted therapy. Neoadjuvant means before the surgery, we are giving upfront chemotherapy and targeted therapy. So most of these patients, actually, when we do surgery after that, we don't find any cancer. we don't find any cancerous cells alive. That is called pathological CR, pathological complete response. And such patients actually have a wonderful prognosis. So that is one part where we are giving first chemo or chemo target depending upon the type of the tumor, then surgery in between after some 2 to 3 months of chemotherapy. Then after surgery, the remaining part of chemotherapy is given. And depending upon 3 types of tumor, as I also highlighted, Dr. Raj also told that if it is the majority group like estrogen receptor HER2 positive group, then depending upon the stage, if the tumor is large or it has reached axilla, then we will require, after completion of chemotherapy, we will require radiation therapy as well. Radiation therapy. Also, for early stage tumors, for ladies which surgeries, breast conservation surgery has been done, complete breast is not removed, only a part is removed, tumor's part, small tumor, and then axillary clearance, that is called breast conservation surgery. For such patients also, radiation therapy is a must. So, a breast cancer patient has to be treated by a medical oncologist, a surgical oncologist, and a radiation oncologist. So this treatment will actually take around 6 months time in majority of the cases. Special cases like those patients who are target receptor positive, like HER2 positive. So we are actually completing 1 year, full 1 year of targeted therapy, trastuzumab. That is not a chemotherapy. There are very few side effects. There is just a financial side effect because the drug comes a bit costly. But still, 1 year, if we complete it, it saves many lives. So it's just curative treatment is one-time treatment. We have to hammer it. We have to actually fix it and do it in a very, very professional and a planned manner so that we don't leave any scope for the tumor to recur. So this is 6 months intense treatment followed by maintenance. For estrogen receptor positive, as Dr. Raj correctly told, that the data is somewhere at least 5 years, we should give some tablets which are targeting on the hormone receptors. That is an additive thing from our side because that tablet will keep the tumor from coming back. So that is actually a good thing that we are treating for 5 years or 10 years so that this disease doesn't get any chance to come back because we have got that target, estrogen receptor. If that is positive, then we have to give that tablet. It's minimal side effects are there. They are perfectly manageable. As we all know that is the commonest disease. So millions of patients have taken this hormone therapy for 5 years and 10 years without much problem. It's perfectly manageable. But they are in the guidelines for a reason because these tumors, if you don't target the hormone therapy, don't give that 5 years of adjuvant or 10 years of adjuvant hormonal therapy, then they are notorious to come back. And whenever they come back, they are stage 4. So stage 4 tumor, treating a stage 4 tumor is a difficult thing. It is an endless thing. Because in stage 1, 2, and 3, it's a one-time treatment and you are good for your life. Next 20, 30, 40 years you can live there. You will not die of cancer. That is the aim for curative setting. But for stage 4, it is a chronic disease. You have to keep on treating till the patient's disease progresses on those therapies or has unanswered toxicities or till death, basically. So it is just like I actually tell all my patients of stage 4 breast cancer that you deal with this like diabetes or hypertension. For that, you are taking a pill. Here also, we have got wonderful pills which with minimum side effects for estrogen positive or for HER2 negative. We have got very wonderful target therapies, which actually we are moving away more and more away from chemotherapy, and we are going more and more into the targeted therapies and hormonal therapies, which are actually feasible, which can be actually taken on a chronic basis for years together because stage 4 has no cure as of now. Stage 4, you have to actually counsel them, and I am being a medical oncologist. Majority of my patients are stage 4 patients. So I have to deal with them only. So we have to actually counsel them in depth that, yeah, the tumor will never go away from your body, but we will keep it at bay and you will be able to live your life as a whole in a very, very normal way. That is how we have to develop that mentality to treat stage 4 breast cancer.
Thank you, Dr. Beva, for explaining that very well, that what are the treatment options, and like people should be positive about that. And yes, there is a treatment, and once the treatment is done, you can be cured. Like Dr. Neeraj, I want to come and ask you, like apart from the medical and the surgical management in breast cancer, what are the other aspects to be that that we need to talk about, like the support care, the emotional and the psychological support? What would be the best way to do that?
Well, As both of the speakers said, we are now working in an era of organ preservation. Like it's not only curing a case of breast cancer. We also want to optimize the cosmetic outcome, because losing a breast is like a mental trauma for a female. So of late, the standard of care is to go for breast conservation surgery whenever a breast cancer is diagnosed in an early stage, and that is the reason many of the breast cancer patients, especially young patients, where the tumor size is less, but if it is node positive or they are desirous of breast conservation, we usually advise them to go for neoadjuvant therapy. That means definitive treatment, chemotherapy before definitive treatment, and reduce the size of tumor, and then go for definitive treatment like surgery. Surgery is indispensable as of now. However, it should be like minimal excess surgery. Like surgery should be as much less as possible, so that the cosmetic outcome can be preserved. Yes, if a large part of breast is to be removed, one can also consider for, or post complete mastectomy, one can consider for breast reconstruction. So these are important components. It really is a mental trauma, and it affects psychologically. Many of the females who have been completely removed with their breast and axillary dissection develop upper arm swelling. We call it as lymphedema, and this disproportionate swelling of arm on one side and normal hand on the other side also looks ugly for them. So psychological aspect is very important. Maybe around 20 to 30% of females who are taking treatment for breast cancer, or for that matter any other cancer, are suffering from depression, and we have to involve clinical psychologist or psychiatrist for their regular consultation. So apart from that, the treatment related issues like chemotherapy related side effects, radiation related side effects also takes a toll on their body, and they either gain a lot of weight or lose a lot of weight, and because of which they lose their lose their confidence over self confidence. So nutritional aspect, psychological aspect, issues related to side effects are certain things which needs to be addressed apart from treating a female patient, especially young female patients.
Thank you, Dr. Neeraj, for highlighting that. Also, there is a very important aspect about people are worried about that whether they'll be cured of breast cancer or not. When we talk about the future of the breast cancer treatment, what is the future of the breast cancer treatment, and in terms of the precision oncology and the more of the targeted therapy that people can use that, and that can also control the disease in the future, and what are the future prospects of that?
Well, as of now, if the awareness about breast cancer can be increased and breast cancer can be diagnosed in earlier stage, it is a potentially curable disease, regardless of its mutation status. Although some of the diseases like triple negative, ER/PR, HER2 negative diseases tends to be biologically aggressive, but then they are still curable if they are diagnosed in early stage. So with availability of treatment options like targeted therapy, of late, in fact, there are 4-5 generations of anti-HER2 therapy which have come up in last 3 to 5 years only. Till now, it was only trastuzumab for HER2 positive cases. Now, even for triple negative treatment, ER/PR and HER2 negative cases, the option of immunotherapy is approved. In fact, it is on. Many of the patients who can afford the cost of immunotherapy can have good response to triple negative breast cancer in advanced stages as well as in neoadjuvant setup. So regardless of the type of breast cancer we are dealing with, the thumb rule is if it is diagnosed in earlier stage, no one has to worry. The chances of cure are very bright. As you said, or as you use the word precision oncology, even in radiation therapy, there are various techniques available which reduces the radiation scattering to surrounding normal structures like heart or lungs or esophagus, and chances of future complications because of radiation are very less. So oncology actually is going towards minimal access surgery, precision oncology, in the sense that the complications, all the efforts are being made to reduce the complications of treatment. At the same time, one sees to it that the treatment, the cure rates are not compromised, as well as the optimal cosmetic outcome is optimized.
Thank you, Dr. Neeraj. We hope that this is what the future of the breast cancer treatment is. Dr. Raj, in the same lines, in terms of the surgery, like the minimal invasive surgeries which are available today, so is it applied for the breast cancer surgery as well? And are there much advanced surgery options for the breast cancer?
Definitely. So there was an era where we started talking about radical mastectomies or extended radical mastectomies, where we were performing removal of the entire breast, removal of the muscle behind the breast in front of the chest wall, removal of all the lymph nodes in the armpit, because the entire focus was on loco-regional treatment. Whereas a surgeon, the implication was that, okay, you remove the breast and the muscle and the axilla, then patient is going to be fine. But subsequently, when we realize that breast cancer is not a localized disease, it is a systemic disease, where breast is probably only the local manifestation of the disease. So from that, the treatment became more and more precise. So it is like I usually call, only a large incision does not mean that the surgeon is good. Smaller incisions also make big surgeries or good surgeons which are there. So now we are doing more and more like organ preservation surgery. Now, in organ preservation surgery, it is not only preservation of the breast, but it is also preservation of the axillary lymph nodes if it is not required to be removed. See, if Dr. Neeraj mentioned now about lymphedema, swelling of the arm, the risk of lymphedema after doing complete axillary dissection is in the range of 5 to 7%. But those unfortunate 5 to 7% ladies who develop lymphedema, it is very, very morbid. It is very, very disturbing. So now in those patients who have an early breast cancer, who have a node negative axilla, as we call it, where clinically there are no nodes, radiological there are no nodes, we do a procedure called as Sentinel lymph node biopsy. In Sentinel lymph node biopsy, we remove only the affected nodes, get a frozen section biopsy where the report is available within 15 minutes at the time of surgery. And if the average, we should have at least 3 nodes. If the 3 nodes do not show evidence of spread, then there is no need of removing all the nodes. So the risk of developing lymphedema completely goes away. Or even in those patients where you have to do a complete lymphadenectomy because there is a node positive axilla, we can do a surgery called as lymphovenous shunt. We do a prophylactic lymphovenous shunt surgery at the time of surgery to ensure that the lady does not develop lymphedema in the future. And neoadjuvant chemotherapy, as both my medical oncology colleagues were saying, neoadjuvant chemotherapy helps to downstage the size of the tumor. And those patients who are like, we call them as large operable breast cancers, where there was a large tumor, 5 centimeter tumor in a small volume breast. After giving chemotherapy, it reduces to 2 centimeter. Or in case of triple negative breast cancer or HER2 positive breast cancer, we are also concerned about an entity called as surgical. So where we are planning a neoadjuvant chemotherapy, where before the operation, when we are planning to do a chemotherapy to the patient or give targeted therapy to the patient, as a surgeon, I insist on putting a clip in the center of the tumor. So we place a small breast coil in the center of the tumor, start the chemotherapy, because after 3 or 4 chemotherapy, it happens that the entire tumor disappears. Even mammography cannot pick up the tumor. Then the question becomes, where do you operate on the patient? It has to be done, because pathological complete response will be documented only after you have removed the tumor or the tumor area. So when you have a clip which is placed in the center of the tumor, after the chemo is done, we tend to remove that part of the breast area and subject it for biopsy. So if we have seen patients who had a 4 or 5 centimeter tumor, and the final tumor area which was removed is hardly 1.5 or 2 centimeter, which shows no evidence of disease. And with reconstruction facilities available, even at the time of surgery in breast conservation surgery, when you remove the breast area, equal importance is given to breast cosmesis. So we do a oncoplastic surgery wherein surrounding area of breast tissue is mobilized to ensure that the cavity is filled and the overlines both the breast cosmesis or looks similar. Or we can do a flap, a latissimus dorsi flap, which is a muscle which is taken from the back to fill in the cavity in the breast tissue. In selective patients, we put in silicone implants, or we can take flaps from the anterior part of the abdominal wall also, or tram flap as we call it as. There is one more point which I would like to make it over here, that there was a thought process for quite a long time that doing breast conservation surgery is more focused at the quality of life of the patient or breast cosmetic outcomes. But now enough of evidence has come, there are published meta-analysis which show that ladies who undergo breast conservation surgery in fact have a better survival as compared to those who undergo mastectomy. So even in those patients who have similar breast tumor characteristics. So if a lady has got the same type of tumor biology, same type of tumor size in two different ladies, and one undergoes mastectomy, the other one undergoes breast conservation, it has been proven now that the lady who undergoes a breast conservation has a better survival outcome. So as a surgeon, when I'm offering a patient breast conservation, it is not only from cosmetic point of view. Many a times patients or their caregivers have a false notion or a misbelief that if you do not remove the breast, the risk of the tumor coming back again is very high. Actually, that is false. Whether you do breast conservation with radiation or you do mastectomy, the risk of locoregional recurrence is 1.4 to 1.8% only. It does not change. But the overall survival is better in those patients who have a breast conservation surgery. And it is very important that women who undergo breast conservation surgery, it is of paramount importance to explain them before the surgery that if the breast conservation surgery has been done, then that lady has to take radiation after the surgery. You cannot avoid radiation after breast conservation surgery. But it also means that if a lady has undergone mastectomy, does not mean that she may not require radiation. After mastectomy also, if the tumor is more than 5 centimeter or if there is axillary node positive, the lady is still likely to get radiation. So breast conservation is from cosmetic outcomes for quality of life perspective and also from survival point of view. It is important.
Thank you, Dr. Raj, for explaining that very well and making us understand how important is like the entire process of the treatment and the like as you explained about like very in detail about this. Doctor, like coming to an end about this in this session, we would like to highlight like a very important point. Like we spoke about the treatment process, we spoke about the diagnosis, but then there is something called how do we eliminate this at a very starting point. So how, Dr. Weber, starting from you, like how can we eliminate the probability of acquiring a breast cancer? And is there, can you also explain, are there any vaccines for breast cancer? Or maybe is there a way that a younger woman who is maybe like they are also worried, they also can get a breast cancer. So what is the probability that we can eliminate the breast cancer?
So yeah, I will again take the second part of your question first, that are there any vaccines available? No, not at all. Not at all. No vaccines are available right now. There might be few of them for research more for specific variety of tumors, but there is no approved vaccine to prevent breast cancer right now. That should be the take-home message. This actually is the decisive statement that there is no vaccine to prevent breast cancer. Second, very important question that you asked, how can you eliminate the risk of breast cancer? How can you make the risk zero that some lady should never develop breast cancer in the lifetime? Now, actually knowing cancer so deeply at a molecular level and treating so many patients, ultimately, one of my teachers actually used to say that forget about breast cancer. The only sure shot way of avoiding any cancer is not to be born. Right? If you are born, obviously there is some data to it. CR database also says that there is still, if you live for an average year of around 70 years, which is around life expectancy here in India as well, you are supposed to get some cancer of some part of body because of the environmental influences, environmental changes, not particularly because of genetic. In breast, that genetic element is 5 to 10% that can be taken care of by, as Dr. Raj told, genetic counseling, genetic testing, and there are different set of rules for that particular cancer. But majority is environmental. Environmental means our lifestyle. We have adopted a Western lifestyle, increased weight, that leads to increased amount of breast cancer, alcoholism, cigarette smoking. This needs to be cut down. There are scientific studies to it actually. If we cut this down, then obviously the risk of breast cancer reduces. Breastfeeding improves, actually decreases the chances of breast cancer. So there are documented studies which show that if you breastfeed for more than a year in your lifetime, maybe 1 kid or 2 kids, whatever, then your chances of getting breast cancer decreases. Maintaining an ideal weight, maintaining activity, eating healthy foods like fruits and all in your diet, all these things go a long way. Adopting a healthy lifestyle goes a long way, and avoiding alcohol and cigarette, as well as post-menopausal hormonal therapy, as people were very fond of earlier, but then it actually increases the chances of breast cancer. Even there is data that OCPs also, after a point of time, after a particular age of 35 years, they also contribute to increased risk of breast cancer. So these are the things which will decrease the risk of breast cancer, but it cannot eliminate it altogether.
Thank you, Dr. Vaibhav. Dr. Neeraj, your takeaway points, and also how we cannot acquire breast cancer. What are the lifestyle changes you would suggest?
Well, this is regarding hormone-dependent cancers. Like for breast cancer, it is hormone-dependent cancer in female. Prostate is hormone-dependent cancer for male. Hormones actually are the very existence of our very essence of our existence. We cannot remove hormones from our body. So as long as estrogen is there in the body, a female is likely to be affected by breast cancer. Same way, testosterone is responsible for prostate cancer, and prostate cancer cannot be sort of completely eliminated as long as we are living. So what we can do is we can just modify our lifestyle and see, there are two kinds of risk factors. One is modifiable risk factors, another is non-modifiable risk factors. Genetic factors are something which we do not have control over, so that we cannot modify. But modifiable risk factors, as Dr. Vaibhav told, may be addressed, and if they are properly taken care of, we can substantially reduce the burden of cancer, or especially breast cancer, from the society. So this is what I would like to convey to all the audience.
Thank you, Dr. Neeraj. Dr. Raj, your takeaway points.
I think, as both my colleagues have rightly put it, the most important takeaway point would be every lady should be aware and should reiterate herself that yes, I am born a lady, and there is, and breast cancer is the most common cancer in women. So I am at risk of developing breast cancer. So how do I prevent breast cancer? Lead a healthy lifestyle. That is most important. Even after leading a healthy lifestyle and following a regular health checkup, getting an annual mammography done after the age of 40 years, and taking care of a good diet, yet you are likely to develop a breast cancer. But in case you are going to develop a breast cancer, it is best to diagnose it in stage 1, where you can treat it with minimum surgery, minimum chemotherapy or oral therapy, minimum radiation, and ensure that you lead a normal, healthy, long life. So being aware that you are at risk is probably the best way to understand. And again, as a surgeon, my message to all those ladies who prevent telling their family members or reaching out to a doctor even after noticing a breast lump, because of the fear that if you go to a breast, most of the ladies know that they have a breast lump which could be cancerous, but they avoid going to a doctor with the fear that, okay, now my breast is going to be removed. So they tend to feel that their femininity might be lost. And so for them, I would suggest that now with the current multidisciplinary team approach which we follow, more than 90% ladies, breast removal is not required. So please do not delay your treatment with the fear that we are just going to do a mutilating surgery like mastectomy.
Thank you, Dr. Raj, for that. And in the last, I would like to say, thank all of you, Dr. Raj, Dr. Neeraj, and Dr. Weber for joining us and talking about a very important issue, like how we can reduce the risk of the breast cancer, and also talking about the very interesting facts, like how is the diagnosis being done, what are the treatment options, and the future treatment of breast cancer. So my message for all the listeners would be take care of yourself, be healthy, and do not be worried, because there are treatment options available, and there are best doctors available who are ready to treat you, and breast cancer is treatable. Thank you everyone for joining us for this session, and on behalf of the IHW Council and I would like to thank all the doctors and Dr. Reddy's for supporting us and for creating this awareness about the breast cancer. Thank you everyone. Have a good evening.
Thank you very much.
Thank you.